are now live.
Hello, good morning. This is a Nanjing First Hospital Cath Lab 4. So today there will be 2 live demonstrations of complex PCI. It's our great honor on behalf of Professor Shaoliang Chen. I'm Dr. Junjie Zhang, Vice President of Nanjing First Hospital. First, let me introduce our team. The first case, the prime operator is Dr. Yu Wei. So please, Dr. Yu Wei, introduce your team and your case information.
Okay, thank you, Chief. Dear moderators, panel audience, and good morning. We are very happy to show you this live case transmission. On my right-hand side is Dr. Wu Xiangqi and Dr. Gan Jinxiang. The 2 doctors will assist me to perform today's case. And we also have 1 technician, also our the head technician, Dr. Panto, and we have 2 nurses, nurseman and nurse Showman and nurse nurse Jia. Okay. Next, I'd like to invite Dr. Wu to introduce the case history for you.
Thank
Dr.
you.
Please.
Good morning, our expert. It's my pleasure to show the patient's information. Patient, 80 years old, mate, chest pain for 10 days with fastest not, positive cardiac biomarker, low eGFR, normal ECG, and UCG, lab 2, 3, AVF, V, 3 to 2, 6 is ST7 depression. We diagnose this patient is not STEMI, CHD, NST. Next. This is baseline angiographic result. We see the position show the proximal and the middle segment of RCA is a serious nasal lesion accompanied with calcified lesion, and the distal lesion is borderline. Next. We see the cranial LAO showed the proximal and the middle segment of AAD is serious nasal lesion, accompanied moderate and serious calcified lesion. And we see the distal of AAD is borderline lesion. Next. This is IO the CAG result. Next. Then we use the syntactic score to evaluate the patient with the stratification. We see the syntactic score is very high, but the patient age is old and reluctant to accept cabbage. So we choose the PCI strategy for this patient. Next. Left child, we use a 3 stand to solve the proximal and middle segment of the RCA. Use the 3 stand. Next. However, the patient has seizure again, so this time we solve the LC8. And what is the strategy to treat the calcified lesion? A plain balloon dilate, iris, a plain dilate, rotate or survey balloon and get the iris. That's all. Thank you very much.
Okay, thank you, Dr. Wu. Very brief and clear case introduction. As you can see, the patient is high-risk level patient and with the right dominant, and we have performed the previous PCI and 3 DZS to cover the ICA disease. And today, can you see our today's angiographic left con artery? You can see very clearly the previous stent in the proximal segment of the circ, and also for the distal circ with the first obtuse marginal is also a Medina 0112 buccal lesion. But today our target lesion, please switch to the cranial view. It's LAO cranial view very clearly. It's diffuse lung lesion just involved from the proximal LAD to extended to the distal LAD. And the prox segment of IOD, you can see very severe, heavy calcified lesion, and also with the angulation more than 45 degrees. Next, please. Okay, this is our today's angiography. So before that, we just talked with our team and guided by our chief, Professor Zhang, and we just made our schedule today. Because our target lesion is LAD, severe calcified lesion, we perform the IVUS As we all know, the subgroup data analysis, the data from the subgroup analysis of the ultimate study to us, for the severe calcified lesion group, the IVUS-Guided PCI has the privilege when compared with the angio-guided PCI. So IVUS casts very smoothly, just we send to the distal segment of LAD. Okay, Dr. Panto, would you show us the IVUS image?
Okay, let me show the IVUS imaging. The first one, we check IVUS from the distal LAD to left main. And here we can see the distal LAD vessel is normal. The vessel diameter about 2.6 millimeter. And here, this point is the distal landing zone. Then pull back, we can see eccentric plaque. Then go and pull back, we can see the bifurcation. This is the diagonal, small diagonal, and the small septal. And the distal landing zone near the bifurcation about 6 millimeter. Then go and pull back, this is the distal LAD. And the distal LAD vessel diameter about 3.0 millimeter. And the plaque is an attenuation plaque. Then go and pull back, we can see calcified plaque, but the calcification angle is not more than 180 degrees. So go and pull back. Here we can see another bifurcation. Here we can see the diagonal 2 we are joining LAD. And here this is the LAD and the diagonal 2 bifurcation. Then go and pull back, this is the middle LAD. And here we can see the calcification angle and more. Here, and this is the minimum lumen area, and here the calcification angle is more than 270 degrees. And here the lumen is just 1.4 millimeter. Then go and pull back, and here the vessel diameter is about 3.5 millimeter. Then go and pull back here. This is the LAD and the diagonal 1 bifurcation. Then go on withdraw the IVUS. This is the proximal LAD. And here, the proximal LAD, and this point is the proximal landing zone. And here the lumen diameter is about 3.6 millimeter. Then go and pull back. Here, this is the circumflex. This is the LAD and the circumflex bifurcation. And then go and pull back, this is the left main. The left main vessel is normal. We measure the narrowness from the distal landing zone to proximal landing zone is about 64 millimeter. From the distal landing zone to LAD and the diagonal 2 bifurcation, the narrowness is about 40 millimeter. Okay, this is a baseline IVUS imaging.
Okay,
thank you.
Thank you, Dr. Panto. Very clear evaluation. So, Chief, and
yeah, I think from the IVUS imaging, Dr. Panto has interpreted very clearly. It's a very diffuse lesion from the proximal LAD to very distal LAD. But the severe calcification actually from the angio and also from the IVUS only located at the proximal to mid LAD. So according to the IVUS measurement, the proximal LAD, I think the significant lesion, the minimal lumen area diameter only 1.4, and also associated with a very superficial and a very awful circle superficial calcifications. The arc is more than 300 degrees. So Dr. Yue, for these typical severe calcification lung lesions, I think when before you plan put a stent, the prepare calcified modification is very important. For this lesion, what's your strategy? You will use only cutting balloon, NC balloon to the predilation, or will use rotablation, or even you will use IVL treatment?
Okay, Chief, just according to the IVUS results, we can calculate the IVUS calcium score more than 2. And just from the severe calcified PCI format, I think we need to use the rotational arthroectomy or the IVL to preparation this lesion, just to acquire the very good stent expandation. Yeah, I agree with you. Just according to the IVUS calculation, we can see the minimal diameter for the severe calcified lesion is less than 1.5 millimeters. So our strategy, we decide to perform the rotor first, to perform the modify the calcified plaque. Then we check IVUS again, just to evaluate whether we can dilate the calcified lesion.
Yeah, I fully agree with your options for these particular calcified lesions. So rotablation or 1.5 burr first, then check the IVUS and then make a decision. So go ahead.
Okay.
Dr. Yu.
Okay, Chief. So we have just delivered the 1.5 burr just nearby in the proximal LAD. Okay, ready? We just test the loader burr, and we just initially burr size we use the 1.5 millimeters, and want to use the high speed rotablation. Dr. Pan is in high speed mode.
Yeah.
No,
High speed.
high speed mode.
Yeah.
Okay, we will perform the first rotor.
160.
Okay. We just
160.
okay. We just gently touch the lesion.
The speed is
10.
Yeah.
160,000 RPM.
15.
And the
15. Okay.
The speed
Okay.
is maintained
19.
very stable. So it takes, I think, 10 seconds. Yeah.
Yeah, less than 50 seconds. We just give an interval for the fluid infusion to the distal LAD.
The patient is stable and the hemodynamic is stable without any ECG change. Then we stop and take the blood supply to the distal cardium. Then we start the rotablation again.
So Dr. we have the speed deceleration.
160.
Oh, 降速多少?
No.
Just
More than 5,000?
yeah.
I just feel the resistance when I just touch the lesion. Over 30 seconds, just let us know.
I think it's okay.
Okay,
seconds
okay. So
already,
Chief,
yeah.
we just perform the second rotor.
Second round.
Okay, second round.
160,000.
Yeah. There is some
5
resistance.
seconds.
Yeah,
Okay.
I can feel.
Here is our target, very severe and circle superficial calcified lesions.
15 seconds.
15 seconds.
Okay. Second round.
Yeah.
Maintain 50 seconds. Still some resistance.
Yeah.
And the speed is decreased more than 5,000 RPM.
Yeah. But fortunately, the bird just go forward.
Okay. You mean the bird has crossed the lesion?
No, not fully cross the lesion.
Okay.
Yeah.
Maybe still we need the third round.
Yes, third round.
Time zero. Okay.
Okay, 30 seconds.
Yeah.
Okay.
Yeah, 30 seconds.
30
Okay, the
seconds.
third round is ready.
Yeah, ready.
160,000. 5 seconds. 10 seconds.
Yeah.
Okay.
Nice.
Yeah.
Okay.
Pass. Yeah.
The hemodynamic is stable without any ECG change. Do you need any tests to check the flow?
Yeah. Okay, Chief. Okay, flow is
Yeah,
good.
flow is good.
Yeah.
Good. I think after 3 round rotablation, we have successfully closed the significant lesion of the proximal LAD. Do you think we still need the 1 or 2 round rotablation?
I just want
polish.
I just want to see. Okay, yeah, we can use the 1.5 polish.
Yeah.
Just because the angulation for the second, just at the side of the second diagonal, more than 45, I can see small dissections.
Okay.
So I just want to check IVUS to see if whether we have the wire bias. If the wire just bias to the normal vessel wall, maybe we should stop birth size escalation.
Okay.
Maybe IVL will be safe.
So I think now we can pull out the
post round. Maybe so Chip, can we use the polish, low speed polish?
After the polish.
Okay. 还要降速14万 OK 哦
OK
14万降14万好 OK we use the low speed polishing
seconds.
Yeah. No speed deceleration, right? Okay, very smooth.
15 seconds.
Okay, I think we can finish Chip.
Yeah. Very nice.
Before retrieve the burr, I will test first.
Yeah,
Okay, flow is
very
good. Yeah.
Without complication.
Low
Nice.
speed.
Low speed.
Okay, Chief. So we retrieve the burr.
Sure.
Okay.
Be careful. Yeah.
Yeah. Just give me the microcatheter.
With a low speed and maintain the wire tip at the distal area. Yeah.
Okay. The Chief, we just use the microcatheter to retrieve the wire, to exchange the wire. Or the workhorse wire.
Workhorse wire.
Okay.
Yeah. For these scenarios, consider very long lesions, and what do you think? You will use only workhorse wire, or you will use some stiffer support wire?
Okay, support may be better because after all, it's the long lesion and with the angulation. Extra support wire, please.
Extra support. Slam wire, yeah.
Till now, the patient's hemodynamic stable, no symptom. Yeah.
Very good. Considering it's elderly patient, 80-year-old gentleman, and also the EGFR only 60.
60, yeah.
So it's I think it's CKD 2 to 3 stage. So we should save the contrast medians.
Yeah.
Extra support.
So this is why we choose the IVUS-Guided, not the OCT-Guided.
Yeah, that's a very important point. Actually, for complex PCI, intracranial imaging guidance was associated with a long-term follow-up result compared with only angio guidance, according to our ultimate 3-year trial.
Yeah.
Actually, recently we combined the XPR data and our ultimate data, do the patient level analysis, and the results show at 3-year follow-up, IVUS guidance, long DES implantation, the length longer than 28 millimeter, can result in a significantly lower rate of cardio death.
14.
So especially for this high-risk patient.
So Chief, next I just want to recheck the IVUS.
Sure.
Okay.
So actually, in terms of IVUS guidance PCI, actually it's not only before and the post-standing, but also during the procedure. Like this case, after rotablation, before we decided to do the further plaque modification or standing, we should check the IVUS to see the result after rotablation.
Okay.
So it's a SLAM super support wire.
Yeah,
very nice.
Yeah.
Very good.
Yeah,
very nice. Okay, I think it's enough because distal we did not touch.
Okay,
so we can go to more proximal. Yeah.
Yeah, I will refer back for the distal LED. No more.
It's a normal segment.
Yeah.
So Dr. Pan, you can interpret the IVUS image.
This vessel is about 2.75. Here, see eccentric plaque. One side branch. I would say tooth distal. Distal LED here vessel is more than 3.0 millimeter.
Very eccentric fiber plaque. Just as the mid LED. Yeah.
This segment is balloon dilatable lesion. Maybe NC balloon preparation is enough.
Yeah. Is there any dissection? This is a site.
Maybe
just between the septal and the second diagonal. Yeah. This gives some flush.
Bubbles. Okay.
We can also see the reverberation.
Yeah.
3 layers. Yeah.
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 Maybe the lumen diameter more large.
There is a broken segment at 9 o'clock.
Yeah.
Yeah.
The shifts, we still have the more than 180
This is diagonal
degrees
one.
continuous calcium, superficial calcium.
Yeah, you can see
Yeah.
here there is
Yeah.
some small broken segment.
Yeah, we can also see the minor crack. But for the proximal segment, because the vessel diameter is big, maybe 1.5 Br is not enough. Okay.
Okay, I will
Okay, we
stop.
finished. Okay.
So Dr. Pan, can you focus proximal to mid LED severe significant and do analysis? Then we make a decision.
The lumen diameter is more large, more than
me some-
1.8 millimeter.
Give me some ATP, please.
Okay. So, but still, I think there is a superficial calcification. The broken crack is not enough.
Yeah.
So maybe we still need IVL treatment,
yeah.
further IVL treatment,
Okay.
get a better plaque modification before we put a stent.
Yeah, we agree. So Dr. Fan just calculates the diameter of the vessel diameter.
3.0.
0.
So
Okay.
just reference vessel size.
Yeah.
3.0, okay.
3.0.
So next step we'll do the IVL treatment with a 3.0 shockwave balloon. Okay. So it's a typical I think combined treatment with a rotablation and IVL treatment for this severe calcification before we put a stent.
Okay, Chief, we just deliver the balloon.
Okay.
Seems okay.
Yeah. Please
Okay.
give some tests.
Okay, test please. Test please. I think we don't need it. Okay, just here.
Yeah, here. Yeah,
okay.
it's good.
Okay,
yeah, it's good.
Just go. 4. Yeah, 4
So
please.
first
4.
we go
4.
up to
4.
no.
4.
4. You have some bubbles, so the balloon not show very clearly.
Yeah.
What's the matter?
So actually we have started shook with this IVL device. The first round, we up to the atmosphere to 4.
Yeah, 4. Yeah. Okay, going up to 6.
Now it's up to second round. We're up to 6 atmosphere, fully inflation the shockwave balloon.
Retrieve, please. Okay, Chief, I will retrieve the balloon for the middle segment.
Okay.
Okay. 2 seconds.
So we pull back the balloon to the more proximal side.
When I want to retrieve the balloon, pull back the balloon, I feel some resistance.
Yeah.
Okay, please go. 4, please. 4. Okay, 6, going up to 6. Okay, done. Because we don't use the pure contrast to repair the balloon, so the balloon variable is not good. Okay, I'll retrieve the balloon again. Still feel some reason. Okay, go. 4. Going up to 6.
Yeah. Then one more round again.
Yeah, this we have finished the third round. Maybe we need the 4th round.
Yeah. It's the 4th round.
Yeah. Okay, I will just pull back the balloon to the proximal segment. Okay, here, go. 4, please.
The patient have some symptom. Yeah. I think be careful the guiding. Cubing too
going up to 6. We can see the balloon expand good. Well,
Yeah,
okay.
I think the balloon shape is a fully expansion. Yeah, which means I think the superficial calcification has been fully shooked. Okay, very nice.
Chief, I will take a picture for you. Okay. Let's see.
From the ECG monitor, I think when
EKG
AVR, the ST segment a rate elevation. Yeah.
Sorry. Okay, please take a picture. Go. Okay, seems very good.
Yeah, I think we lost a very small, the third diagonal.
Third diagonal,
yeah. Maybe I think if the BP is okay, we can give some nitro.
Okay, give some nitro.
Yeah. But the first diagonal and the second and the first diagonal is still there. Yeah.
Yeah. Maybe some spasm for the vessels.
Yeah.
All the vessels.
Yeah.
Seems spasm. Okay, give me some nitro, please. Wait a second. I will engage guiding calcified. Nitro, please. Again.
Nitro again. Yeah.
Nitro again. 200 is enough. Okay. Wait seconds.
Wait 30 seconds.
Okay, wait 30, yeah, 30 seconds.
And also you can see the ST elevation at the 1 AVR is better resolved. Yeah. Just to mention, I think this may be the spasm after rotablation and the IVR treatment.
Yeah. Okay, we'll take picture for you. Okay,
sure.
Okay, better than before.
It's large spasm. Yeah.
So, Chief, I think next for the distal segment, we need the NC balloon to prepare the lesion.
Sure.
Okay, give me 2.5 NC balloon.
2.5 NC balloon.
2.5 NC balloon.
The proximal lesion prepare after rotablation and the IVR is quite good.
Before that, do we need to? To recheck IVUS.
That's okay. I think after we do the balloon pre-dilation, we can check the IVUS before we put the stent.
Yeah. Okay.
So it's a typical stepwise IVUS guidance, severe calcification with rotablation and the IVR treatment. So I think after ultimate trial, I think nowadays all of the world of our intervention field, the intracorneal imaging, especially IVUS guidance, complex PCI is now
8.
Have a very high penetration rate.
10,
In
12,
our cast lab, I think
14.
The IVUS guidance complex PCI is nearly 100%.
14?
Not only for the trial, but also for the daily practice.
Okay. So this segment is just balloon dilatable. We just use the nominal pressure. Yeah, it's 2.5 NC balloon.
What's the balloon size? 2.5 by 15?
By 15, yeah.
Okay.
15 nice. Going back to 12? Sure.
Prepare some GTN after balloon dilation.
Okay.
We will check the IVUS.
Okay. Go. 12. Okay. Go. 12. Okay. Okay, I'll give some natural to check IVUS again. So till now, patient's blood pressure is okay. No ECG changes.
Yeah.
Okay. So IVUS again.
IVUS guidance complex PCI can save contrast volumes.
Okay.
Yeah.
Dr. Pan, please go pull back.
Yeah, looks very smoothly.
Not a segment, not normal segment. Okay, here, go.
Yeah, okay. Normal segment.
Distal LED. No more. 2.5 millimeter.
And maybe vessel still have this spasm.
Yeah, I think so. Yeah. It's hemodynamic smaller compared to the baseline IVUS image. Yeah.
You can see minor dissections.
Yeah.
Yeah.
Dissection at the 11
Here,
o'clock.
dissection.
Yeah.
Involving, I think, a medium. Yeah. A very, very essential plaque. Heavy plaque burden. That's a middle ARD. Yeah.
Medial dissection.
The vessel size is up to 3 millimeter. The deeper calcification. Yeah.
The chief for the distal segment, I think 2.5 stent DGS.
Yeah, I
Okay.
think it's enough. Yeah.
Okay. Prepare 2.5 by 38. Yeah.
According to the baseline IVUS measurement, the total length is 64.
Yeah.
So maybe 238 stent is enough. Overlap 4 millimeter. Yeah.
Okay.
The first one is 2.5. Second one is 3.0.
3.0.
Yeah. Both lengths is 38 millimeter.
The chief here we can see several cracks.
Yeah, I think so.
Yeah.
11 o'clock and 1 o'clock. Yeah.
I think it's dilatable.
I think if I was sure there at least 2 crack point, which means when I put the stent can full expansion. Yeah.
Okay.
It's a proximal ARD
We still
landing
can,
zone.
yeah, one crack.
I think it's a landing zone. Yeah.
Okay.
Okay,
me-
good.
Yeah, give me the first stent. 2.5.
2.5 length.
Yeah.
So after IVUS imaging, we confirm the result.
So chief, do we need a big size NC balloon or modified balloon to modify the proximal segment?
Yeah, I think so. We will do the post dilation with something like for distal we'll use 2.5. For middle we will use 3.0. For proximal, I think maybe 3.5 is suitable.
Okay.
To do the post dilation according to the IVUS imaging result.
Okay. Please. Just test.
It's a longer stent so far we have. A nice delivery. Very nice.
Because we use the extra support guide wire.
Yeah, it's very important.
Okay.
Nice.
Okay. Test, please. Maybe I have to do this though. Okay, take a picture. Take a picture, please. Okay. So chief, I think here is okay. Just the last diagonal.
Think so. Yeah.
Okay, just inflate. Inflate it to 6, 8.
What's the nominal pressure?
8.
10.
10.
Yeah.
Long
10.
time inflation at least 15 seconds.
15 seconds.
Long stent, long time inflation can achieve the stent full expansion.
Okay.
It's very important. Let's take a cine to see if we have got optimal expansion.
Okay.
And times off.
Okay.
We have given the seat. Okay. Wait a second. I will retrieve.
Nice. Okay. Retrieve a little and do the post dilate.
Okay. Please.
Long time inflation.
Go. Inflate. Inflate.
Okay.
12.
Yeah.
We still use a stent balloon to do the post dilation up to 12 atmosphere to achieve the stent wear expansion. Of course, we still use NC balloon to do the post dilation. Okay, go.
12. Okay, so chief, I think we need still need the modified balloon. Okay, done.
Yeah,
because the proximal does not expand very well.
Okay.
Yeah. Take a picture. Please take a picture. Wait a second. I will engage guiding first. Okay. Take a picture, please. So chief, this is the 38 lens, maybe 33 or 36?
Yeah, I think 33.
36.
36 is
36. Okay.
36.
36.
Okay.
Okay. Before that, chief, do we need cutting or NSE to prepare the proximal lesion? Because
I think we should use.
yeah, because I think the stent does not expand well for the proximal segment, just according.
What's the
It's the
inflation atmosphere, the previous 2.5 NC balloon?
NC balloon for the 16.
Yeah,
Yeah,
maybe we should upsize the NC balloon 2.75 with the high pressure.
Okay, 2.75 2.75 high pressure balloon.
Adding a little pressure, a little damping. Yeah.
Okay. We just deliver the 2.75 NC balloon.
Yeah.
To pre-dilate the proximal segment. Okay, here, go, inflate. 10. Normal pressure 12, 14. Okay, seems better. Yeah, seems better.
Yeah.
I retrieve the balloon. Okay, go.
Here is the site we should do the high pressure. Yeah.
14, 16. Okay, better than before. Go. 12, 14, 16.
Now is better.
Okay, go. Okay. 12, 14, 16. Okay, better. I'll give some nitro and take the picture. Nitro, please. Ready? Okay, take a picture, please. Okay.
Yeah, it's good.
Yeah, to diagnose seems okay.
Yes.
So Chief, do we need to protect to diagnose? Seems okay.
I think it's okay.
Okay.
Yeah.
Okay, thank you. Give me a 3036.
36.
Yeah. Just according to the IVUS results, Chief, I think we need the big size balloon for the proximal segment post dilation.
Yeah, I think so.
3.5, right?
Yeah, at least 3.5. Yeah, for proximal. Be careful the wire tip. Okay, good.
Wire supporting is very good. Strong support. Okay, wait a second. I think we need to retrieve.
Yeah, we can retrieve more
bit.
proximal. Yeah.
Just overlap too long.
Yeah.
Okay. Just take a picture, please, here. Okay, Chief, we overlap nearly 4. Do we need to retrieve a bit more or?
I think we should pull back a little.
A little, okay.
Avoid overlapping at the septal branch.
Okay.
Maybe we lost it. More proximal, yeah.
Okay.
Okay, here is
yes, good. Okay.
Picture again.
Picture, please. Okay, just
here.
Here.
Good.
Okay, go.
Nice position.
10, 10, 10, 12.
Long time inflation.
Okay, inflate. Done. Okay, inflate. 15 seconds. 15 seconds.
Yeah. Longer stand,
Yeah,
long time inflation, achieve optimal stand expansion.
Okay. Again, prepare the 2.5 NC balloon. Shotgun, 2點唔該啊，準備。Okay, 15 seconds. Done.
$2.5跟3.5
台上有的
都准备。
台上有的。1 second.
When put out to the stem balloon, should be cautious. The guiding tip intube too much because the proximal stem maybe not fully positioned. the intuber of guiding cast tip will be induce stent deformation. Yeah.
Yes, Chief. Because when I retrieve the long stent the balloon, I feel
Yeah.
resistance. The guiding cast just dip seat.
Yeah. Good.
Okay. These two segments flow is good.
Good. The first
okay.
diagonal flow is only maybe a TME1. Yeah.
TME1.
We should give some nitro.
Nitro. Give some. Okay.
And do the post dilation. I thought for this we still use a 2.5 NC balloon. Yeah.
2.5. Okay.
2.5.
Then for proximal, I think for
2.5.
middle we will use a
NC,
3.0.
2.5.
And for proximal we will use a 3.5.
Okay.
Yeah.
2.5.
2.5. No, it's not.
And prepare the 3.0 and the 3.5 balloon.
It's not NC. It's Quentin.
Give me a 2.5 NC balloon.
NC. New one. 2.5. NC. Okay, Quentin.
So the bigger is better.
Yeah.
So not only for BMS area, but also for DES. The cutoff value according to ultimate trial, there is 3 criteria. The first is minimum stent area should at least 50 millimeter square. Or stent expansion larger than 0.9 for small vessel, small stent like 2.5.
16.
And also the proximal distal to the stent edge, the plaque burden should less than 50%. And without
16,
the
18.
dissection involve the media longer than 3 millimeters.
20.
All these 3 criteria achieved, we can divide the IVUS-guided optimal PCI. So 1 year TVF only 1.6. So we should not only use the IVUS, but also should follow the IVUS optimal criteria. Nice, from the angel.
3.0.
Still, we will use a 3.0 NC balloon to do the post dilation for the mid RD stent segment.
New one. 3.0. New one. 3.0.
Okay, after the 2.5 post dilation, I will give a picture.
Oh, nice.
Yeah, very good.
Nice.
3.0.
Okay, now we are inserted the 3.0 NC balloon.
Yeah.
To post dilate the middle segment. Okay.
Yeah.
Wait a second. Okay, going up to 12 first. 12 first. Okay, 14.
14.
Okay, done. Okay, here. 14.
14.
16.
16.
Okay.
For proximal signal, it's very important. We should
Yeah.
up to high pressure. Yeah.
16.
Gradually, I think. Gradually.
18. 20. Okay. Done. Okay, 20 please. Okay, done.
Yeah, it looks balloon shape. It's nice expansion. Yeah.
Yeah. Okay, 3.5 balloon. Prepare the IVUS up to the post dilation. We will check the final IVUS. This is the 3.5 balloon.
3.5.
Yeah, 3.5. Okay.
Give some tests. Check
Okay,
the
test please.
position.
Test please. Okay.
Yeah, here it's the right position.
Inflate.
Inflate.
Inflate. Go. 12.
12.
14.
14.
16.
16.
Okay, done. This this is the 15 lens. So
Yeah.
just touch. Okay, this is the proximal segment. Okay, go 16, please. 16.
Position, precisely position is very important.
Okay, 18, 20.
18, 20.
Okay, done. Seems like a balloon expand well.
Yeah, very good expansion.
Okay, I will give some nitro and take the picture.
Nitro,
Yeah, I will give nitro.
some nitro. Nice, huh?
Yeah, both diagnose is good. The two diagnose is good. Okay.
Yeah.
Yeah.
Still there. For first and the second and the fourth diagonal.
Yeah.
Good.
So Chief, we will check the IVUS for.
Okay, go ahead. We'll see what we have got. Is it optimal? According to the ultimate trial criteria,
Yeah.
there is 3 individual criteria. We should achieve all 3 criteria. Then we can get the excellent result in terms of the long-term follow-up for this patient.
Okay, Dr. Pan, IVUS delivering
Okay.
normal segment. Okay, please
I
go
will
back.
pull back. This is normal.
Normal segment. The landing zone is good. Side branch is coming.
Yeah.
Now vessel is larger. Maybe stent is coming.
Okay, Chief,
This
yeah,
this
stand coming.
stand age is normal. No
Normal.
dissection.
Okay.
Yeah, very good.
This stand diameter about 2.5.
2.5.
Yeah.
Yeah.
So Chief, I have a question.
Mm.
Before we have the IVL, we only have the big size burr for the big vessel. I mean, maybe the diameter more than 3. Yeah, how, what's your experience in lesion preparation for the big size severe calcified vessels?
Yeah, actually, this is a very difficult scenario. So before the IV available, actually, maybe 2 or 3 years ago. So the only way to the debarking we have in our CAS lab, even in all the Chinese intervention community, is a rotablation. So
Only
for the largest burr, we have a
largest
2.0.
burr,
Yeah. Sometimes very difficult for big size vessels. So after rotablation, I think maybe if there is some crack, we have chip, we can use sequentially use a cutting balloon and do the post dilation. But even though we still cannot get the optimal lesion prepared. So that's why in our ultimate trial, only 6% lesions and 51% patient will achieve ultimate optimal IVUS-Guided.
For the severe calcified lesion, right?
Yeah, that's why for all the lesion, I think majority the contribution is the severe calcified lesion.
Okay.
So far, when we now the IVL is available, maybe the optimal achievement criteria may be higher compared to previously.
Okay. So maybe for the big vessel of the severe calcified lesion, we need the rotor combined with the IVL. Maybe it's the best choice for the lesion preparation.
I think so. Hybrid therapy. Yeah. Okay. You see the proximal?
Proximal.
Yeah, looks good.
Proximal.
Stand wear position and the expansion. Yeah.
Still in stand segment.
Yeah. Maybe a circumflex is coming.
Yeah.
Oh,
okay.
Nice.
Seems
nice
good.
Location without any age dissection.
I think it meets the ultimate 3 criteria.
Yeah.
Dr. Please calculate.
Yeah. I will stop.
Nice. Please do the analysis for the IVUS image.
Okay.
To tell us if we have achieved the optimal ultimate criteria.
So Dr. please. Yeah. Yeah, it's a distal segment, right?
Yeah.
This is a minimal stand area.
Okay.
Before it's a small stand, 2.5. Maybe I think 5.0 is not not suitable for this scenario. I think stent expansion larger than 0.9 is suitable for this scenario.
Yes, the distal reference vessel is just 4.5 millimeter.
4.5.
So the expansion index is more than 0.9.
Okay.
0.9. Okay.
Okay.
The distal is okay, right?
Yeah, and the proximal is okay too, no dissection.
Yeah.
And the plaque burden is not more than 50.
Okay.
So
Can you
the-
measure it?
Yeah.
The plaque burden. It's very
Yeah.
important. It's a site because it's a proximal LD. Yeah.
Yeah. So the result is consistent at mid-trial.
Okay.
Less than 50%.
Yeah, I think less than. Must be less than. Okay. 41.
Yeah,
41.
I
Yeah.
think. So, Dr. Yu, I think according to the IVUS analysis, we have achieved the ultimate optimal stent expansion.
Okay.
So it's
So we can finish the case.
yeah, sure.
Okay. Thank you, Chief.
So I think, Dr. Yu, can you give some summary for this case? Then we will switch to the next lab. Dr. Yi have prepared another challenger CTO pulse bifurcation case.
Okay, thank you, Chief. I think for just like Professor Zhang, our chief, have told us, for the big CV calcified lesions, lesion preparation seems very important before the DGS implantation. So that's why for today's case, we use the rotor just modified to easily let the IVL balloon to pass through. So we use the 1.5. It's just different from the old times we use the big size burr to perform the debarking, because for nowadays we rarely to use big size bone just to get rid of the incidence or complications of the rotational atherectomy. So today 1.5 just to let the IVL balloon. IVL seems better, seems safe, much more safer when compared with the big size balloon rotablation. So you can see the final results just meet the 3 criteria of the ultimate criteria. I think we can finish the case. Thank you all. Thank you very much.
Okay.